Hello, I'm Anne Mejia-Downs, and this presentation is about airway clearance techniques. It is part of a post-acute COVID-19 exercise and rehabilitation project, the PACER project. This course is intended for educational purposes and does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. Also, remember that this content is current at the time of dissemination. However, evidence and science on COVID-19 is evolving rapidly and subject to change. Here is some information about me, for a bit of my background, my experience in airway clearance techniques comes from my years at the University of North Carolina hospitals working with the cystic fibrosis population. As such, I spent many years taking courses, attending conferences, practicing these techniques. These are the objectives. At the conclusion of this module, the participant will be able to identify indications for breathing, coughing strategies, and airway clearance techniques, compare and contrast a variety of airway clearance techniques, determine the optimal airway clearance technique for a given patient, and describe the components of a normal cough and a huff cough to clear secretions. So a note before we get started. Remember that COVID-19 pathology causes pulmonary edema and infiltrates in the lung tissue, not pulmonary secretions in the airways. So while breathing and coughing techniques may be indicated depending on the patient's presentation, specific airway clearance techniques for excess secretions may not be indicated. Refer to Dr. Tepper and colleagues' presentation of the pathology of COVID. So what is airway clearance? Airway clearance includes all methods of sputum mobilization and expectoration. So it is more inclusive than what some people might call chest PT. In the US, many of these techniques I will review are performed by respiratory therapists. So I don't know why it's sometimes called chest PT. In addition, we don't talk about neck PT or knee PT, so I really do prefer the term airway clearance. The goals of airway clearance are to improve ventilation and gas exchange, to improve mucociliary clearance, and to reduce airway obstruction. Airway clearance requires airflow. If there's not sufficient ventilation to move secretions through the airways, then strategies to enhance ventilation may be useful. This is where thoracic mobility can come in, talking about posture and positioning, as well as breathing strategies, positioning, lower costal breathing, incentive spirometry, and inspiratory muscle training. These are a list of the techniques that I will review under the categories of thoracic mobility and breathing strategies. So let's start with thoracic mobility. Optimal movement of the thorax improves ventilation to clear the airways. So to get more ventilation into the lungs, the alveoli, we really need good thoracic cage mobility. Some of the indications for increased thoracic mobility are decreased chest wall movement. In the case of scoliosis, Parkinson's disease, scleroderma, these are cases where the chest wall has some restrictions, and so thoracic mobility needs to be enhanced with different techniques. Also, in cases of restricted lung expansion. So, for example, pulmonary fibrosis and cystic fibrosis both have fibrotic tissue in the lungs, which restricts the lungs from expanding in the alveoli to perform gas exchange. Also, thoracic mobility would be helpful with limited diaphragmatic excursion. In the case of obesity, where obesity presses up on the diaphragm and doesn't allow it to descend fully for good deep breaths, or hemidiaphragm paralysis. Thoracic mobility may also be indicated for shortness of breath. This is where COVID, sorry for the spelling error, COVID-19, patients with COVID-19 might need this. One of the key symptoms of COVID-19 is shortness of breath. So when you want to improve ventilation to affect or improve shortness of breath, you might try improving thoracic mobility. So here's how posture can be corrected to enhance thoracic mobility to make sure that we get ventilation into the airways. Cervical extension. If you place yourself in cervical flexion and try to take a deep breath, you will see that you can't inhale fully. So putting your neck in cervical extension helps to get more ventilation. The same is true of scapular retraction. When your scapula are protracted, it restricts thoracic mobility, whereas scapular retraction will enhance thoracic mobility. So try these yourself to see how a change in posture can affect airflow. Another tip is shoulder flexion. So with the arms down, you don't get a good breath in, but if you time breathing with shoulder flexion, putting the arms up overhead, you will find that that will also enhance thoracic mobility. Optimal positioning also enhances ventilation to clear airways. So we see here two things we can do to position a patient. In the supine position, you see this roll lengthwise between the scapula. So here's the person rolled onto the bolster or the roll. You can use a rolled up towel or a bolster, whatever you have, but you can see that it's going to open up the chest to enhance thoracic mobility. Also in the sideline position, if you put a roll or a pillow or a bolster under the side in sideline, it will open up the non-dependent side. Other ways to improve thoracic mobility involve using rotation maneuvers of the trunk, similar to the diagonal lifting PNF pattern, if you know that. It's a rotational movement. Also, we know that manual therapy can help enhance thoracic mobility. So myofascial or soft tissue release, as well as mobilization to the thoracic vertebrae and the ribs. Also, physical therapists know many exercises for stretching the thorax. So think about how you can use those exercises to enhance thoracic mobility. Now we'll talk about breathing strategies. And this is a great diagram for reminding us that when you breathe in and your chest expands, the ribs elevate, the diaphragm descends to let the lungs fill. When you breathe out, which is a passive maneuver generally, the diaphragm relaxes and comes up and the chest contracts. So optimal breathing is necessary to really help with ventilation. So these are some breathing strategies that might improve ventilation. And the indications for applying these strategies are decreased ventilation, such as we might find in the post-operative patient with atelectasis or lung collapse, or someone with pain from a surgery. Also restrictive dysfunction, something like pneumonia, which causes a restriction and doesn't allow for optimal ventilation. Breathing strategies would help with this. Also decreased endurance. So there may be many progressive neurological conditions where breathing is fine at rest, but with prolonged activity, it becomes more difficult. And so breathing strategies may be appropriate for these conditions. And then finally, shortness of breath. Again, this is where COVID-19 comes in as a symptom. Shortness of breath is a symptom, and using some of these breathing strategies might help to improve this symptom. So let's talk about positioning and how that can enhance breathing. You see here a picture of a person prone on elbows. And because you're restricting the abdomen in this position is going to facilitate upper chest breathing. So if someone has trouble ventilating in their upper chest, this would be a good position for them. Also, we need to remember that supine is not a good position. Lying in a hospital bed is not a good position for optimal breathing. Sitting upright or standing is going to increase diaphragmatic excursion and help with ventilation. This is a picture of the tripod position. So anchoring the forearms, the arms on the thighs, or you will see people anchoring on a lectern, for instance, supporting themselves on a shopping cart, anything where they can fix their upper extremities, and that will help with the use of accessory muscles of ventilation. And then here's a picture of prone positioning. We know that prone positioning improves oxygenation, and this is a key component of treatment for COVID-19. It appears to be preventive for mild to moderate symptoms, so even people that aren't on a ventilator, but it is a very important position for people with severe COVID who require mechanical ventilation. It has been reported that patients with COVID on the ventilator respond instantly to proning, to being in a prone position, in that their oxygen saturation improves immediately. So prone positioning is something that you can try to improve ventilation. Another breathing strategy, we call this the butterfly technique. You sit with your hands behind your head, your elbows out to the side, and then you're going to inhale with your elbows back and exhale with the elbows coming together. So this enhances ventilation. You can combine this also with rotation, so that diagonal PNF pattern rotation can help with breathing strategies. One of the most common breathing strategies that all PTs should be able to use with patients is lower costal breathing, sometimes called diaphragmatic breathing. And this is indicated to increase expansion in the lower costal area. So there are many patients who will, when you observe their breathing pattern, they'll be using their accessory muscles of ventilation excessively. You might see them using their upper traps and seeing their shoulders rise with breathing. And what we want to do is get them to use their lower costal area instead. So the way we would teach this is to put your hands for tactile pressure on the lower ribs and give pressure during inspiration, saying, breathe into my hands, so that the person feels the tactile pressure and pushes against the hands to try to get more air into the lungs. Your instructions may also be, put one hand placed on the upper chest, the hand of the patient, and one hand on their abdomen. You tell them, keep your chest still and let your abdomen move up and down. So they should see no movement in the chest, the hand up on the chest, the upper chest, but the hand on the abdomen should be moving up and down. Some other ways to teach this are to use self-resistance. You can use a gait belt or something to resist the lower costal area, or you can use TheraBand around the lower ribs. And this is a good way to resist inspiration, again, giving the person a tactile pressure to breathe into that resistance. Another way to provide feedback, some patients respond well to something very light on the abdomen, a tissue box, for instance, so that they can see it rise and fall with their breathing in and breathing out. Some patients respond better to a pressure, a cuff weight. So you can put something that weighs, a weight on the abdomen and tell them the same thing. you can observe it rise and fall with ventilation. So you're trying to have them push this up toward the ceiling, whether it's the tissue box or the cuff weight. You can see in this video lower costal breathing being demonstrated in supine. You can see the hand on the upper chest very still, the hand on the abdomen moving up and down. Also, we want to make sure when we're teaching lower costal breathing that we teach it in supine, which is the easiest position to teach it in. But then we're going to move to upright sitting, and then to see if the patient can continue to use lower costal breathing in that position. And then also progress to standing and see if the patient can, in the standing position, continue to use lower costal breathing and leave that upper chest still. And then finally, making sure that that patients can use this lower costal breathing technique during activity. So put them on a stationary bicycle or a treadmill, or have them do whatever activity is functional for that patient, and make sure that that this carries over from the other positions so that they can maintain lower costal breathing during activity. So it's easiest to learn in supine, and then it becomes more progressively difficult with these other activities. Other breathing strategies are to use an incentive spirometer. And here is a video of the use of this. What you want to tell the patient is to use a maximal slow inspiration. So breathe in deeply and slowly to try to keep that little indicator raised. And make sure that the patient is sitting upright for this. They shouldn't be lying down in bed supine. The indications for using the incentive spirometer would be decreased ventilation, or to re-expand the lungs after someone has been on mechanical ventilation, or to prevent atelectasis or lung collapse. It's usually more helpful to tell the patient to use this several times during the hour, so that they're using it through the day and not just one time and then putting it aside. But this incentive spirometer will really help with inhalation and expanding the lungs. Sorry about that. Was describing pursed lip breathing as a technique to enhance exhalation, to try to get the trapped air for somebody with COPD, to try to exhale more of that trapped air. Pursed lip breathing creates a positive expiratory pressure, so it keeps the airways open longer so that more of that air can be exhaled. With pursed lip breathing, make sure that you are that you have a hand on the patient's abdomen so that you can make sure that they're using abdominal force instead of just passive exhalation. So normally exhalation is passive, but with pursed lip breathing, we want them to use their abdominals and use a forced exhalation to get that air out. Pursed lip breathing also helps to decrease respiratory rate. So even with somebody who doesn't have COPD, but has, for instance, anxiety with shortness of breath. Most people with shortness of breath do have a component of anxiety, of course. So this might help to just slow their breathing and to decrease anxiety. It also helps with exhalation to remind patients to exhale with effort. and you want to have them avoid breath holding or the Valsalva. And one way to do this is to have them count aloud so that you're not allowing them to hold their breath. Another strategy for inhalation, or trying to get more air or volume into the lungs, is an inspiratory muscle trainer. Some of the indications for using this device are restrictive pulmonary dysfunction, respiratory muscle weakness in the instance with many neuromuscular conditions, and ventilator dependence it's been used with, and neuromuscular disease. This device is called a threshold device, and it provides resistance to inhalation. It's recommended to start at 30% of the patient's maximal inspiratory pressure, and then increase it up to progressively increase up to 60% of that maximal inspiratory pressure. To measure this maximal inspiratory pressure, you need to have a manometer. So a respiratory therapist might have the equipment needed to have this measurement. It's also been shown that, especially for ventilator dependence, that sets and repetitions are more effective than prolonged use of an IMT. So 4 sets of 6 repetitions for strengthening the diaphragm has been found to be more effective than, say, a 15-minute session twice a day. In this video, you can see that it's important to use the nose clip so that the person is definitely breathing just through their mouth and they're not cheating by using the nose. This device it's spring loaded, so you can take off the mouthpiece and turn the spring to the indicating the correct force, and then to take deep breaths in. Again, you're breathing against a resistance, and so this is going to strengthen your muscles of ventilation and make it easier to inhale. Other breathing strategies, paced breathing. This is where you're going to incorporate pursed lip breathing and lower costal breathing into functional activities. For example, you might use it for someone who has difficulty stair climbing. Many people with shortness of breath, when they see stairs, that they need to climb stairs, they will try to go too quickly. And this is a way to have them pace their activity so that they're not going too quickly, and they can use their energy more efficiently. So you have them breathe in through their nose and walk to a count of 1, 2 as they breathe in, and then exhale through pursed lips and to a count of 1, 2, 3, 4. So it helps them pace or slow down their activity. So when they get to the top of the stairs, they're not so short of breath that they can't, take another step forward. So this strategy of paced breathing is useful for stair climbing, and it's also helpful to have the patient use the handrail so that they can use their accessory muscles. Paced breathing, though, can be used for any activity in which somebody is having trouble with their endurance. Other breathing strategies are to encourage deep breathing are to use bubbles. This gives you an automatic pursed lip breathing activity. There are several toys and things that you can use for blowing, and any kind of musical instrument that involves blowing or breath control. Those things can all help with breathing, as can voice. Voice is also an instrument, a musical instrument that uses much breath control, and so you can enhance breathing with that. Now we're going to talk about specific airway clearance techniques for patients that have excessive pulmonary secretions. So the indications for this would be chronic bronchitis, bronchiectasis, cystic fibrosis, and asthma. So conditions where a patient is producing excessive secretions. So again, when we talk about COVID-19, we're not so much concerned about excessive secretions being produced in the airways. So with COVID-19, the fluid or the excess fluid is in the lung tissue. It's in the form of pulmonary edema and lung infiltrates. It is not like with chronic bronchitis where you get pulmonary secretions in the airways. So again, these specific techniques probably are not going to be appropriate or needed, indicated for people with COVID-19. These are the airway clearance techniques that I will talk about: postural drainage, percussion, vibration and shaking, active cycle of breathing, autogenic drainage, positive expiratory pressure, high frequency chest wall oscillation, and exercise. So let's start with postural drainage. This is maybe a technique that you learned in your physical therapy program in lab, where you used gravity-assisted positions. This is sometimes called bronchial drainage, and to drain the secretions out of the lungs from the periphery, or the smaller lung segments, into the central airways so that they can be coughed or expectorated. Head down positions, so below horizontal, which you might have learned in physical therapy in your program, they really are to be avoided, and these are now modified with just a head of bed flat position. The reason that we don't do head down positions anymore is that it was found that many patients have reflux, esophageal reflux, not even sometimes during postural drainage, but after postural drainage. And this has been shown to cause a lot of problems. So it's recommended, and now you will see most people teaching this properly, to not use the Trendelenburg or head down positions, but to just use head of bed flat. The physiology behind postural drainage is to use gravity to promote the clearance of these secretions in the segments that in the airways that are affected. But there's also evidence that shows that changes in position change lung ventilation, and that promotes drainage. So we know, for instance, that turning someone prone enhances their ventilation, and that also might be why we can get some drainage of those posterior lung segments when we're in that position. So this is a chart used by the Cystic Fibrosis Foundation. And you can find this on their website, modified postural drainage positions. Again, they're modified because you can see that none of these positions have the original head down positions pictured. So when we are working with lower lobes, you can put the patient prone, but we don't do head down tipped. So any of the those old positions have now been modified to just use head of bed flat. So what are the advantages of using postural drainage? Well, it's passive, so it doesn't take any effort from a patient. So if someone is has a chronic condition, or they've got an acute exacerbation, and they really don't have the energy to put into assisting with an active technique, then this is a passive technique. So they don't have to work to have somebody, put them in a postural drainage position. In the hospital, you can coordinate it with nursing care. So as we turn patients every 2 hours in a different position, we can coordinate the postural drainage with that. The disadvantages of using postural drainage to clear airways are that when you use it by itself, it takes a long time. And as you can see in this list here, there are many contraindications. So the ones in bold here are contraindications to postural drainage in general, and then the other ones are contraindications to the head down or Trendelenburg position. So head and neck injury, hemorrhage, hemoptysis, and pulmonary edema. Again, pulmonary edema is what happens with COVID-19. So we do not want to be putting someone in postural drainage positions for COVID-19 because it is a contraindication. Esophageal reflux is the most common reason why people have trouble with the head down position, but also increased intracranial pressure, uncontrolled hypertension, and the risk of aspiration are all contraindications to using head down position. So again, the head down position is not recommended. Head of bed flat is what is recommended. The next technique is percussion, sometimes called chest clapping. And this is a force that is applied rhythmically with cupped hands. Or you can use a mechanical percussor, pictured here, to the thorax over the involved area. These also, you can use these cups that are pictured here of different sizes for adults down to children. But the real key to do it manually is to use cupped hands. So cupping your hands so that they can actually hold water in them, that kind of cup. And air is trapped between the cupped hands and the thorax, and that's what causes this hollow sound when we're doing percussion. Percussion is performed by a caregiver with the patient in those postural drainage positions that we talked about. So using those modified positions, placing the patient in whatever position they need to, depending on where the secretions are in the lungs. And then the energy is transmitted through the chest from the air trapped under your cupped hands. That loosens secretions so they can move proximally for the patient to cough them out. The advantages of chest percussion are that it shortens the treatment from using only postural drainage. So it's very rare that someone just uses postural drainage, but they will accompany this with percussion to shorten that treatment. Some patients are very soothed by the rhythm, so they really do enjoy having percussion done to them. And in chronic conditions, it's very familiar. So, for instance, a child diagnosed with cystic fibrosis might have a parent do percussion from the time they're very young, and so it's a very familiar technique to them as they need it as they age up. The disadvantages of percussion are that it requires a caregiver. So you can apply percussion to yourself in maybe the anterior upper lobes, but you really can't really completely do the positions needed by yourself. Also, there is a risk of repetitive motion injuries. Caregivers have reported carpal tunnel syndrome from doing percussion over a long periods of time, and it can be painful. So here are a list of contraindications to chest percussion, including osteoporosis, osteomyelitis, subcutaneous emphysema, spinal anesthesia, open wounds, burns, or grafts. It can cause bronchospasm, if there's lung contusion or somebody with a recent pacemaker, coagulopathy, and then of course any chest wall pain. So you can see there are numerous contraindications to using percussion as an airway clearance technique. Shaking and vibration are techniques that are used after percussion because they are applied only during the exhalation and also in postural drainage positions. So shaking is more of a bouncing maneuver to the rib cage, with hands over the involved lung segment. It's often referred to as rib springing. So to use shaking, you should have a rib cage that's pretty flexible. Vibration, on the other hand, is a smaller, it's lower, higher frequency, but lower velocity of movement, a sustained co-contraction of your upper extremities with your hands on the segment that's involved, and it transmits a vibratory motion. Both of these, shaking and vibration, are applied by a caregiver only during exhalation, and again in those modified postural drainage positions. And this shaking and vibration works again because it enhances the secretion clearance, mucociliary clearance, by mobilizing the secretions and helping them move from the periphery to the larger central airways. Advantages of shaking and vibration. With your hands on the rib cage, you can have a good assessment of breathing pattern and the depth of respiration. So it's a very hands-on technique that gives you feedback about the patient's breathing. And in that way also, it can be individualized to the patient. The disadvantages are that, again, it requires a caregiver to administer. You can't do this technique to yourself. And it has the same contraindications for percussion. So those, again, are very, very numerous. Here is a video of percussion. You can hear the cupping, the air trapped under the tan.
Now take a deep
and then
breath
following percussion, there's shaking, rib springing
and
with bigger movements, and then here's vibration. Smaller vibratory movements, and then you have the patient cough. So again, on my soapbox, I would implore you not to call it chest PT. It's not the preferred technology. Airway clearance techniques is a term that's more inclusive and descriptive. And again, we don't call it knee PT or back PT. However, when the term CPT or chest PT is used, it usually refers to a combination of postural drainage and percussion and vibration or shaking, all used together. So when you see this in the literature, other airway clearance techniques that I'll talk about later are compared to this traditional technique as the gold standard. Okay, so postural drainage with percussion and then shaking and vibration together. That's the traditional, what I'll call traditional airway clearance. But now we have so many other methods, and because there are so many contraindications to using postural drainage and percussion, many patients are using other techniques and prefer some of these other techniques that I will now talk about. First one is active cycle of breathing technique, which started in physiotherapist in New Zealand, and then it's used extensively in the UK. This technique involves 3 different ventilatory phases, and the idea is to move the secretions from the smaller or the distal airways to the larger proximal airways so that they can be expectorated or coughed out. So these 3 phases, number 1, breathing control. And that's just tidal volume breathing, just easy breathing in and out, not deep breaths in, not deep breaths out, just regular, easy breathing. The second phase is thoracic expansion. This is where you have the patient take deep inspirations, and you can use percussion or shaking with this. the thoracic expansion part of the phase. The third phase is forced expiratory technique. And this is where you're using 1 or 2 huff coughs using your abdominals. And we'll talk about this. Usually exhalation is passive, but with forced expiratory technique, you actually force the exhalation out. So you have to use your abdominals when you're doing this huffing. Here is a diagram of how this might work. So you don't have to use all of the phases one after the other in the same sequence. You can go back and forth as the patient needs to. So maybe they need more breathing control in between the other phases, or maybe they need to use huffing. If they have more secretions to expectorate, maybe they need more huffing interspersed. So you tailor this to each individual patient. Active cycle of breathing is performed, it can be performed independently, or it can be in postural drainage positions, or you can be sitting upright. It works by the breathing control component prevents bronchospasm. So you don't get the bronchoconstriction that will limit the airflow. The breathing control keeps those airways nice and open. The thoracic expansion phase brings more volume into the lungs and promotes collateral ventilation. So collateral ventilation through the canals and pores help the secretions help the air get behind the secretions to actually push the secretions out. So collateral ventilation is an important component of this breathing technique. And then the huffing or the huff coughing it stabilizes the bronchial walls so that they don't collapse, so you can get more of the secretions out. So it opens the airways better for expectoration. So the airway, the active cycle of breathing really depends, a lot of it depends on an effective huff cough. So to do effective huffing or huff coughing, you need to keep the mouth open and keep it O-shaped, and that helps keep the glottis open. So when you do a regular cough, you're actually closing your glottis. With the huffing, you're going to keep it open. You should see the muscles of the chest wall and the abdomen contract as you do a forced huff. And it sounds like a sigh, but it is forced. You need to use long and slow forced exhalation to move the secretions out of the periphery, and then quick, strong forced exhalation to move the secretions to the proximal airways so they can be expectorated. And as you're doing this huff coughing, you should hear crackles if you have excess secretions. Here's a video showing huffing. You can teach patients how to do this with a tissue or a cotton ball. You can put a cotton ball in your hand and have them huff the cotton ball away. So you can see that the first huffs are long and slow to move the air from the periphery, and then the last huffs right here are short and fast to get the secretions to the proximal airway so they can be coughed out. The advantages of the active cycle of breathing technique with the 3 ventilatory phases is that it allows the patient to actively participate. So they have to take deep breaths in. They have to learn how to do the huff cough, and they can perform it independently. The upright positioning of the active cycle of breathing avoids reflux. So we're not putting someone in a head down position. They're allowed to sit upright, which avoids aspiration and reflux. The disadvantage is that you still need a caregiver to do this technique if you're doing it with children, to help them, give them the cues to follow the technique, or with an adult that's very ill to really give them more support and feedback with this. And if you're going to use percussion or shaking, of course, you need a caregiver as well. Next technique I'll talk about is called autogenic drainage. This was developed by a physio named Jean Chevalier in Belgium, and he used this on children with asthma, and it's often used with cystic fibrosis. It's a self-drainage technique using different airflows or velocities of the secretions to mobilize them. So this technique involves 3 phases of breathing. You have the low volume, and when you're breathing at a low volume, very, into trying to get as close to the expiratory reserve that you can, this phase unsticks the secretions from the periphery. Then you go to the second phase, which is just tidal volume breathing, regular breathing, and that's where the mucus collects in the more proximal airways. And then the final stage of evacuation, you're using mid to high lung volume huffs, those huff coughing that I described earlier, to evacuate the mucus from the central airways. When I first learned about autogenic drainage, it didn't sound like it would work at all because it's just breathing. You're not doing anything else but breathing. It does require a lot of feedback to the patient, and it's a more difficult technique to learn and to teach. I don't have a video of autogenic drainage, but this is a picture of me quite some time ago working with a patient trying to encourage lower costal breathing and deep breathing so she can to mobilize her secretions. And when I'm actually doing that technique, my head is very close to the patient so that I can actually listen to the crackles and the quality of the secretions to give feedback about how to change the breathing to move the secretions. Autogenic drainage can be performed independently. Once a person learns how to do it, they use a sitting position and they do it all by themselves. The physiology of it is that first phase, that unsticking phase, ensures that the alveoli are filled using collateral ventilation, so getting air behind the secretions with those pores and channels that are collateral ventilation. The second phase mobilizes the secretion using expiratory airflow, but without having airway collapse. So it's that tidal volume breathing where, yes, there's air flowing, but it's not it's not as forceful of the huffing, which is the next phase, but it collects those. It kind of moves the secretions along from the periphery to the middle airways. And then that third phase really helps to evacuate those secretions. And we're trying to avoid coughing with this and just using huffing to evacuate those secretions. Advantages of autogenic drainage are that it can be performed independently. You use upright positions so that it avoids esophageal reflux, and there's absolutely no equipment required for this. The disadvantages is that it's a method that it takes a while to learn how to teach it, and it takes a while for patients to learn how to perform it. The patient must be motivated and able to concentrate, and so it really isn't suitable for young children. They don't recommend it for anyone younger than 12 years of age. So this is not a technique that you would use for someone who needs to clear secretions short term, say someone post-operatively who has secretions, but this is a technique that would be used more with chronic conditions such as chronic bronchitis or cystic fibrosis. Next technique, I think, is one of the most widely used techniques because it is so easy to teach and to learn, and it's the equipment is very portable. So positive expiratory pressure is the use of different devices that provide resistance to exhalation at 10 to 20 centimeters of water pressure, so that it's not just passive exhalation, you need a slightly active expiration. There are devices that will give continuous PEP, such as TheraPEP down here at the bottom, or oscillatory PEP, so vibratory PEP, like the acapella on the right, the different 3 different types of acapella. So there are different devices that can provide positive expiratory pressure, either oscillatory or continuous. They're used, this technique is used independently in upright sitting, and it takes about 10 breaths per cycle. It works by the principle of collateral ventilation. You've heard that a few times. So that allows the air to get behind the alveoli that are obstructed or collapsed because of secretions, and it allows the air to get behind the secretions to move them, and it also stabilizes the airways to get the secretions out. Here's a picture of a video of the acapella PEP device, and I've attached a device that shows how much water pressure is used. So there's little lines that indicate 10 or to 20 centimeters of water pressure. And so you have to change or adapt the resistance on the PEP device to make sure that the patient is getting the correct resistance. So in this, you can see that the blue indicator shows that there's too little resistance. The patient is able to blow too hard. And so now I've adjusted it to give more resistance. And now you can see the blue indicator is in the middle between that 10 and 20 centimeters of water pressure. So each device has to be adjusted to the individual patient. The advantage of a PEP using positive expiratory pressure is that it's very easy to learn for kids and adults. It's portable, so you can take that, it can fit in a purse or a backpack to be used other places away from home. You can use it independently in an upright position. It also can be adapted to use supplemental oxygen at the same time. So if someone is dependent on supplemental oxygen, that can be used as you're doing the PEP device. And you can also put medication, nebulized medication in there, so that you can inhale the medication and then exhale through the PEP device. So it's a time saver. If you need to do nebulized medications and airway clearance, you can combine them both with this technique. The biggest advantage, though, is that patients really like it. When you ask them, when you teach them several different methods and ask them to pick, the one that they like, it really does have a high degree of patient acceptance. The only disadvantages are that you need to take caution with someone, to be careful with somebody who has acute sinusitis, if they have an ear infection, epistaxis, nosebleeds, or recent facial surgery. Next technique using equipment is high frequency chest wall oscillation, or most people call this vest therapy. It's a system of air delivery that is from a machine that causes the oscillation or airflow and then it gets delivered through the vest that the patient wears. So these air pulses or oscillation, it oscillates the entire thoracic area, and you can vary the frequency from 6 to 25 hertz on most of the machines, and it moves the secretions from the periphery to the central airways. The way it works is that it increases expiratory airflow, so it gets the secretions really moving with exhalation. The oscillatory airflow also decreases the viscosity of the sputum, so it's going to thin the secretions as it helps them to be expectorated. And you can imagine that will come in handy with someone with cystic fibrosis, where the secretions are very thick and viscous. These are different models of the chest wall oscillation machines. You can see that they go as young as age 2, and they fit. They also have, they're individually fit. The vests are fit to each patient individually. And then there's also a more, just the wrap that's not really a fitted vest that can be used for a variety of patients. You can also use it for patients that are in the supine position, but most of the time it's used with patients sitting upright. The advantages of high-frequency chest wall oscillation are that you can perform it independently, sitting upright. It can be used for peds and adults. You can use your supplemental oxygen and your nebulizer at the same time, because of course it's not delivered through the oral cavity, so your mouth is free. And it also can be passive. You can use it in non-responsive patients, rolling the band instead of the vest on them, rolling them in bed to put the device on. The disadvantages is that it isn't as portable as other methods. It has gotten smaller over the years, but it's still not as easy to travel with, say. The other big disadvantage is that it's very expensive, and we're talking thousands of dollars. So that unless you have insurance that will reimburse or support this, if you don't have good insurance, this would not be a method that you could pay for. The final method of airway clearance that I'll talk about is exercise. Exercise does improve airway clearance. That's only one of the many benefits that exercise has, but there are a variety of exercises that can help to mobilize secretions. If you're using exercise for secretion mobilization, it's important to monitor pulse oximetry, especially with patients with pulmonary disease when they're first using exercise or first starting an exercise program, to make sure that they have the oxygen they need, or if they need to have supplemental oxygen with activity. The reason exercise works is that it increases ventilation. So during aerobic exercise, when there is more of a demand of ventilation, that enhances mucociliary transport. So you've probably all seen that when you go out for a run or do a workout, your nose runs, you cough. It really does move secretions. There are so many different types of exercise that can be used with a variety of patients of different ages. So it can be very much individualized or tailored to the patient's needs. Advantages of exercise is that it's normal. It's a normal activity. It's the only airway clearance techniques that normal people do. Okay, so it's performed by lots of us who don't have excessive secretions. It can be performed independently, and there are a wide variety of choices for the mode of exercise that you can do for airway clearance. The disadvantage of using exercise for airway clearance is that it takes, research shows that it takes a great amount of exercise to use it as an exclusive technique to mobilize secretions. So it's usually recommended as an adjunct or a supplement to another technique if you have excessive secretions. So how do you select the appropriate airway clearance techniques? Because we've gone through so many different choices. You need to consider medical considerations. So if a patient does have esophageal reflux, you need to pick an airway clearance technique that is upright, so they're not having trouble with reflux. Osteopenia or osteoporosis, hemoptysis, those things would knock postural drainage off your list. The severity of pulmonary disease. So sometimes if a technique takes too much energy to do, autogenic drainage, for instance, you might not want to do it if someone has severe disease or if they have an acute exacerbation. They might not have the energy to do an active technique, and they might need something more passive. Bronchospasm is something to take into account, as we know that percussion can cause a problem with that. And then there are precautions specific to each of the airway clearance techniques. So it needs to be, you need to consider the patient's individual medical needs. The other thing to consider is the patient considerations. So if airway clearance is something that needs to be done on a regular basis for someone with chronic bronchitis, cystic fibrosis, then it's important for that person to be motivated to continue the technique. And so they need to have input into which technique they're using, and so you can see what their preference is. So some of the considerations to think about are equipment or assistance needs. So does it require a caregiver to do the technique? Is the equipment expensive? Is it available? The age of the patient is another consideration. So some of the techniques will work for pediatric patients and some won't. The ease of learning the technique is important. So how is the person motivated to learn? Do they have cognitive issues that would make it difficult to learn a complex technique? The expense, the insurance or the reimbursement, do they have coverage that would allow them to purchase a high frequency airway or high frequency chest wall oscillation device, or is a PEP device more what is covered? What's the energy cost? So doing exercise for airway clearance might not be the best choice if someone doesn't have a lot of energy and needs to conserve their energy for other activities. Portability, so can they do this? Can they take this technique away from home? Are there time constraints? So do they have to do if they have nebulized medication to do as well, which technique can they do the nebulizers concurrently, at the same time? So most of all, I think it comes down to patient preference. What is the patient willing to do? Which technique do they prefer? Because that's most likely the one that will give you the best results. So this is a chart that you might want to study later or come back to, that where I've listed the techniques, each of the airway clearance techniques, and then talked about different issues with them. The age of the patient, do you need an assistant? What kind of equipment is needed? Can it be used during acute exacerbation? Can you do a nebulizer at the same time? What are the precautions for that particular technique? And then what is the cost? So this chart might help you to figure out which technique or techniques. Some patients like to have several that they will use. Some when they're more sick than others, a passive technique when they don't have the energy to do something active, and then something that they prefer that's an active technique. So patients will pick and choose and have several things at several different stages of their life or of their condition. Okay, so we've gone through breathing techniques and thoracic mobility techniques to improve ventilation. We've talked about specific airway clearance techniques that patients might need. And then finally, we need to talk about, we've gotten those secretions moving, we've improved ventilation, but let's talk about evacuating or expectorating those pulmonary secretions, moving them out and away. So we're going to talk about nasal irrigation, coughing, huff coughing, suctioning, and cough assist. So nasal irrigation is indicated for the upper airway, so sinus congestion, chronic nasal drainage, even snoring, something that obstructs the nasal passages or the upper airways. It's important when people use something like a neti pot, and a neti pot's been around for years, that you use saline solution, not just water. So if you use just water, it doesn't have the salinity that's going to be comfortable for a patient, and that might be a reason why people say, "Oh, I tried that. I didn't really like it. It was painful." Make sure that they're using saline. You can buy saline in the store, or you can make your own solution, but don't use just plain water. So nasal irrigation can help with secretion mobilization and breathing if the problem is in the upper airways. Now I want to review the components of a normal cough. So in order to move the secretions out, to expectorate them, you need to have an effective cough. And the cough is not going to be effective if any one of these components is ineffective. So patients need to be able to have a deep inspiration, so more than tidal volume. They need to be able to hold their breath with their glottis closed. So unlike a huff cough where the glottis is open and the airways are stented open, the cough, you need to close the glottis to build up the pressure, and then in the last phase have a forceful expulsion using your abdominals. It's necessary to have strong abdominal function to be able to have a normal, good, effective cough. And then one key point, always ask the patient to turn their head when you assess their cough. I don't think I need to explain why. Huff coughing we've talked about in terms of using the active cycle of breathing or the autogenic drainage technique. The indications of using a huff cough as opposed to a conventional cough would be pain or fatigue with regular coughing. So coughing really does require a lot of effort, a normal cough, and a huff cough might be a little bit less tedious or energy expenditure for someone with copious secretions. A huff cough keeps the airways open longer, so it stents the airways open and prevents them from collapsing. So you can actually get more secretions out with a huff cough if you have airway collapse. To teach someone a huff cough, the directions would be take a deep breath to build up pressure, keep your glottis and your mouth open, because so most people don't know how to keep their glottis open, but if their mouth is open, that's what helps. And then huff the air out. You want to tell them to use a long and slow huff to move secretions from the peripheral airways. You want them to use a short and fast huff when those secretions get moved to the very proximal airways or central airways, more like a cough. So you can actually move the secretions out without having to do a conventional cough. And it's much less painful, say if someone has a surgical incision or some kind of pain. Some other techniques that might be useful to help with coughing. If someone has an ineffective cough from neuromuscular disease or post-operative pain, or they have a lot of secretions. Remember that the position they're in affects the cough. So a flexed position is going to help to increase the force of the cough. And it's you need to make sure they're in an effective position for using their abdominals. So when someone is lying supine in a hospital bed, that is not a good cough position. You need to either have them roll over on their side so they can bend their knees and flex their trunk, or have them sit up on the side of the bed so that they can lean over for a cough. You only have to think about how you cough, right? Putting your head back to get the air in, and then flexing forward to know that the flex position is really important for an effective cough. Splinted coughing can also help if someone has pain, or they have their post-op, or they have a rib fracture, for instance. So you brace the incision or the place of pain with your hands or a pillow, and then cough. Patients are much more comfortable coughing when they have some support there. Also, breath stacking might be helpful. This is when you need help for someone who doesn't have the ability to take a deep breath in, a deep enough breath in to be able to get a good cough and push the secretions out. So you have to stack the breaths. So tell them, take a breath in, don't let it out. Take another breath on top of that, don't let it out. Take one more breath in, now you can cough. So you build up the pressure or the ventilation so they can cough. If someone is unable to cough, suctioning might be what they need to get the secretions out. To get the secretions out from the mouth, or a tracheostomy, a yank hour can be used. That's an oral device that's attached to suction, and that's an easy thing for patients to use. You use it for oral secretions, or for secretions that have actually been expectorated or coughed out of a trach. But if you need deep suctioning of a tracheostomy, often that requires a competency or a checkoff to be able to do that appropriately. You do need to use sterile technique so that you're not causing infection. You need to remember that the patient's airway is occluded as you're suctioning. So it's important to move quickly but effectively to do deep suctioning of the trach. It's also helpful to hold your own breath when you're doing the suctioning, to remind yourself that their airway is occluded, and to kind of time the duration of the occlusion when you're doing the suctioning technique. And then patients on mechanical ventilation who are intubated with an endotracheal tube. The endotracheal tube can be suctioned. There are inline devices now that decrease the risk of infection, but this often requires a competency as well, a checkoff to make sure that you're doing the procedure appropriately. Again, the patient's airway is occluded during the procedure, so you need to move quickly but effectively. And again, it's a good tip to hold your own breath, to time the duration of the occlusion, and remind yourself how long that person's airway is being occluded. Now we'll talk about just a little bit about cough assist techniques. Mary Massery has some great photos and demos of this, of using these techniques in different positions. So if this is something you want more information on, I urge you to look up her work and her wonderful photos. But basically, you can use a cough assist technique to help someone who doesn't have a strong cough. So if someone doesn't have good expulsion of the secretions, they don't have strong enough abdominals to get a good, strong cough, or somebody with neuromuscular disease. ALS, Parkinson's, spinal cord injury, or cerebral palsy. They might not have the muscular force to have that forceful cough. And then you can do this in different positions, in supine or sideline. So it's if the person can't sit up, you can use those techniques in other positions. There also are self-cough techniques where you teach someone who's alone how to do this, and they can do it in prone, long sitting, short sitting, or you can do a rotation with a cough, kind of, opening up as you come up, and then as you rotate down to try to do the cough at that point. But cough assist is something that you might want to use if someone really doesn't have a strong cough on their own. So here's the instructions. Again, somebody with an ineffective cough because they don't have a good, strong abdominal force for expulsion. Your instructions to the patient are: first, take an easy breath in and out. Now take a deep breath in, hold it, and cough. And during that time that you say cough, you're actually giving them resistance with your hands on their lower thorax to help them push the air out. So you have them move from cervical extension, so take a breath in, and then when you get to the cough phase, you're going to have them flex. And I have a video of this costophrenic assist with the hands on the lower thorax.
Take a regular breath in and out. Take a deep breath in, turn your head, and cough.
So you can see the application of the resistance at the end of the cough to assist the patient to get that expulsion phase, to help them with that cough, and that's called the costophrenic assist. So to summarize coughing, if there's a coughing component missing, you can help them. So if they have trouble doing a deep inspiration, you might work on lower costal breathing, use incentive spirometry, use the inspiratory muscle training. Breath hold, you just have to practice them, the timing of the breath hold. And then if they can't, if the patient is missing a strong expulsion using their abdominals, that's when you can work on core strengthening and then that cough assist. So here's kind of the pathway that we've taken during this presentation. I've talked about thoracic mobility and how that's important to improve ventilation. I've given several breathing strategies to also improve ventilation, because you have to have air to get airway clearance. I've talked about specific airway clearance techniques for the patients who have excessive secretions. And remember that that COVID-19, those patients don't tend to have excessive secretions. They might need the thoracic mobility, the breathing strategies, more than the airway clearance techniques. And then the final stage of evacuating the secretions, getting those, we've moved the secretions, now we want to get them out of there. So again, the goals of airway clearance: improve ventilation and gas exchange, improve mucociliary clearance, and reduce airway obstruction. I would like to thank my husband, who is served as my model and videographer. There is no one else that I would rather be isolated at home with. I would also like to thank Angela Campbell, the president of the cardiovascular and pulmonary section, for asking me to contribute to this worthwhile project. And I would like to thank my talented colleagues who also took part. I have given you several resources and references to look at that describe these techniques, breathing techniques and airway clearance techniques in more detail. So please refer to those if you need more references. Thank you very much for tuning into this presentation.